I'm Kyle Brown, one of the intensivists at Cook Children's Hospital, and today I'll be talking about ultrasound basics. Our objectives for this talk are that the learner will be able to describe the basic physics of ultrasound waves and how different tissues affect our image, also to select a transducer based on the type of exam, to describe commonly used modes of ultrasound and when we apply them, also to describe common techniques for image optimization, and lastly, to be able to distinguish between different types of ultrasound artifacts. So ultrasound is just one of the types of mechanical sound waves. So the frequency of sound that humans can audibly hear is between 20 hertz and 20,000 hertz. Ultrasound is above that frequency and is above 20,000 hertz. To create ultrasound, when we use it for patient care, we use a transducer. And as you can see, there's a power supply to the transducer that creates some type of alternating current. And this current is then applied to piezoelectric crystals. These crystals are compressed, and when they're compressed, they create ultrasound waves that then go out into whatever object we're looking at. At the same time that they can send out ultrasound waves, they can also receive ultrasound waves. And when they're received, they're turned into an electric signal that's then taken back to the ultrasound machine. To discuss this in a little bit more detail, when the ultrasound beam is sent out to the tissue, it's then received by the transducer, and the time that it takes to go to the object back to the transducer is the distance that we see on the ultrasound screen. Different tissues and interfaces of different tissues together create different intensities of signal, and the intensity of the signal is seen as either a brighter or less bright image on the ultrasound machine. In order to better understand how an ultrasound image is made, I want to talk about something called impedance. An impedance is a measure of the resistance of sound as it tries to pass through an object. So for example, with blood has a very low impedance and therefore very low resistance to ultrasound waves passing through it. And so you can see that most of the ultrasound waves are able to pass through blood and very little is reflected back to the transducer. On the other hand, something like the diaphragm has a very high impedance, and so it has a high resistance to ultrasound waves passing through it. And so very little of the ultrasound waves can pass through the diaphragm, and most of the waves are reflected back to the transducer. So objects with low impedance appear dark on ultrasound and are called hypoechoic, and objects with high impedance appear bright on ultrasound and are called hyperechoic. Here's a table with the impedances of different types of body tissue, and I want to make a few points from this. First of all, the ultrasound wave is reflected back to the transducer when it meets tissues that have differing impedances. So for example, if you have fat tissue that interfaces with muscle, because of the differing impedance, there's going to be a reflection of the ultrasound wave at this interface, and you'll see that on your image. At the same time, the muscle and the fat itself is heterogeneous and has different types of tissue within it that have differing impedances, and so even just looking at muscle, you're going to see a certain type of image because of how the muscle looks and because of the makeup of the muscle. So even though liver and blood have the same impedance, they look different on ultrasound because of the composition of each of those and because the differing impedances within those tissues cause reflection of the ultrasound waves back to the transducer. Also, air has an extremely low impedance, and because of this, when it interfaces with any other body tissue, it causes all of the ultrasound waves to be scattered so that none of the ultrasound waves can pass through, and therefore we can't see anything past air on our image, and air makes a very poor acoustic window for imaging other types of tissue. Also, bone has a very high impedance, and so much of the ultrasound wave is reflected back to the transducer, and very little can pass through bone, and so bone also makes a poor acoustic window because we can't see anything past it. So next I want to talk about the concept of attenuation. And attenuation refers to the loss of ultrasound wave amplitude from several different mechanisms. In other words, it refers to the loss of signal returning back to our transducer. So absorption occurs when the ultrasound beam is absorbed by an object and turned into heat. And
These ultrasound waves, when they're absorbed, are obviously not reflected back to our transducer, and so we don't actually see them in our image. Reflection most commonly refers to when the ultrasound wave is reflected back to the transducer, but it can also refer to ultrasound waves that are reflected in other directions and not picked up by our transducer. We also have scattering, and scattering occurs when an ultrasound wave encounters an uneven object or sometimes a circular object, and the ultrasound waves are sent in all different directions, and most of these waves are not sent back to the transducer and picked up by our transducer. And then lastly, we have refraction, and refraction occurs when the wave is traveling at a certain speed through a tissue and then encounters another tissue where it travels at a different speed and it changes direction. So here are different types of transducers. These are the three most common types that we use. You'll see that the curved array transducer and the sector array both create an image that looks like a fan, and so it's more narrow close to the transducer and it's more wide deeper. And these probes are good for imaging larger windows, and they're also of lower frequency, and we'll talk about that on the next slide, but ultimately their lower frequency allow them to penetrate to deeper depths. On the other hand, the linear array probe is a probe that sends out ultrasound waves straight down, and so it creates a square image. The frequency is higher, and so the resolution is often much better. It doesn't penetrate as far, but the resolution is better.
Here's more detail about the different types of transducers. The curved array probe and the sector array probe both create ultrasound beams that fan out from the transducer, and so your image will be smaller closer to the transducer and larger as you get more deep. Like I said, the sector array probe is similar, and the sector array probe is also known as the phase array probe. So you'll often hear it referred to as the phase array probe. And both of these probes, the curved array and the sector array probe, have a lower frequency, and because of that, they're better at penetrating deeper into tissue. On the other hand, their lower frequency creates an image that has a poor resolution, and so the resolution is not as good as the linear array probe. The linear array probe has a higher frequency and therefore has excellent resolution, but cannot penetrate as well. So the curved array probe is good for the abdomen because you have a large probe that can penetrate well. You can see deep structures. The linear array probe, because of its high frequency and great resolution, is good for vascular ultrasound or lung ultrasound. And then the phase array probe or the sector array probe, because of its low frequency, but also because it has a smaller footprint because of the way that it was created, it allows you to get into rib spaces and is very good for cardiac ultrasound, lung ultrasound, but at the same time, because it still penetrates well, it can be used for abdominal ultrasound. Also, the phase or sector array probes actually come in different types of frequency, and so especially in pediatrics, you often need a phase array probe that has a higher frequency, because when you're looking at smaller children, you don't need to penetrate as deep, and so you can get a higher frequency and therefore get better resolution because you don't need the penetration. Also, the pediatric probes often have a smaller footprint, and so they can more easily fit in between the small rib spaces of children. Again, I want to drive home this point of penetration versus resolution. So with a low frequency probe, the wavelength is longer, and because of the longer wavelength, it is not attenuated as much as it goes into tissue, and therefore it has better penetration. But the resolution is poor because the wavelength is longer. On the other hand, a high frequency probe has a short wavelength, and that short wavelength allows for better resolution, but because of the short wavelength, it's attenuated more and the penetration is worse. And so you can see that in the images over here. This is a low frequency probe is able to penetrate deep, but you can't really pick out these structures as clearly. When you have a high frequency probe, the penetration is more shallow, but all of the structures in the image are have better resolution. So another concept is focal zones, and every transducer sends out ultrasound beams that converge on one another, and then past that point they diverge. And it's at this point of convergence that we call the focal zone. So the focal zone is important because at the focal zone, the lateral resolution is the best. And so the resolution between two objects that are side by side to each other will be best.
On the other hand, we have axial resolution, and this is the type of resolution we've been referring to so far. This is the resolution that is from one object that's closer to the transducer compared to the other. And this type of resolution is affected by the frequency of our ultrasound transducers. So higher frequency transducers have better axial resolution.
Temporal resolution is especially important in cardiac ultrasound, and this is the ability of the machine to detect that an object is moving over time. And so this is the idea of the frame rate, and a higher frame rate means that you refresh more quickly and you can pick up small movements over time or quick movements over time, and therefore you have a better temporal resolution. This frame rate and this temporal resolution is really a characteristic of the ultrasound probe itself, but there are some things you can do to improve it. One of those things is just to decrease your depth, because with a more shallow depth, there's less lines for the machine to process and the frame rate can be higher. And some machines allow you to narrow the window. And so if you're using a phase array probe that fans out, the image fans out, you can narrow that image and the machine can have a higher frame rate. Another thing I want to hit on is the idea of the movements of the probe, and it sounds fairly simple, but you'll see when you start using ultrasound that very small movements can make a very big difference, and when you're trying to get a certain image, the movements of the probe are very important. And so this is a mnemonic for different types of movements you can have. It just helps us talk about movements when we're trying to teach ultrasound. One of those is pressure, so how hard you're pressing on the skin. Oftentimes you don't have to press much, and especially with vascular ultrasound, for example, if you push too hard, then you may lose the image that you're looking for. A is for a line, and it's just this idea that you can move the probe over the skin in different directions and to get to the point that you're able to get the image you need. Rotate is another type of movement, and that just means that you're spinning the probe, and this type of movement is very important because it allows you to get the object of interest into the correct plane. And then tilt is another type of movement. Just tilting the tail of the ultrasound probe down or up allows you to fan in different directions and cut through the object of interest in different planes as well. And so you'll be able to play with these types of movements once you start using ultrasound, and you'll see how important they are.
You can hold the ultrasound probe a lot of different ways, similar to holding a pencil, but the most important thing is that we stabilize our hand on the patient. So you can see that he is using the patient to stabilize the probe, and so the probe is more easy to manipulate, and as the patient moves, it also decreases the amount of movement of the ultrasound probe.
Next, we'll talk about the different types of modes with ultrasound, and all ultrasound machines, or most ultrasound machines, have all of these different modes. These are the more basic modes that we use. The first one is B mode, also known as two-dimensional ultrasound, and this is the most common mode that we use and the most fundamental mode as well. M mode is another mode we'll talk about. And then we'll briefly talk about the different types of Doppler modes. The Doppler modes are not really going to be taught in our course initially, but the concept is important and it may be something that we can use down the road. So this is B mode, or brightness mode, and B mode is just the fundamental ultrasound mode that we use most frequently. And so you can see our B mode image here in the bottom of the screen. And I wanted to put this figure up here just to reiterate the way that the machine registers a two-dimensional ultrasound image. So again, you have your probe here, it sends out an impulse, and then that impulse comes back to the transducer. As the ultrasound waves interact with tissues that abut each other, they cause a reflection to come back to the probe, and the strength of that reflection is dependent on the differing impedances of the tissues. And so you can see at this first reflection, you get a signal right here, and then as you get another reflection, you get another signal, and so on. And the strength of the signal is dependent on the differing impedances, and then the ultrasound machine knows where these signals are based on how much time it takes for the ultrasound wave to come back to the transducer. And so by looking at the image this way, it's able to create this two-dimensional ultrasound that we see below.
The next mode is called M mode, and this is a mode we use occasionally for point-of-care ultrasound. We use it for cardiac sometimes, and then we also can use it for lung ultrasound. And you can see up at the top we have our two-dimensional ultrasound image. And with this ultrasound image, we can put a line through it. And with M mode, we only look at the tissue that's within this line. And this is a picture of the heart and peristernal lung access view that's focused on the mitral valve. So as the heart beats, the mitral valve opens and closes, and we can see how that opens and closes over time. So when we look at our M mode, it gives us, over time, it gives us this opening of the mitral valve and approximation of the mitral valve to the septum, and then coming back down, and then with the next beat, it goes back up. And so over time, we see the motion of tissue that's within the line on our 2D ultrasound image. So I mentioned there's several different types of Doppler modes, and I want to review Doppler just so that we understand these modes better. The most common example is that of an ambulance that's moving either towards or away from a person, and the ambulance, when moving away from a person, creates sound with longer wavelengths. And so this sound is picked up as a lower frequency sound. Whereas someone that's on the other side of the ambulance, when the ambulance is moving towards them, it creates sound waves that have shorter wavelengths, and so the frequency is heard as a higher frequency sound. So continuous wave Doppler is shown here, and you can see the top of the image actually gives us our two-dimensional ultrasound image, and we can put a line through this image at our point of interest. And the ultrasound machine and the transducer pick up ultrasound waves that return to the transducer, and it can look at the tissues in this line and determine the velocity of movement and the direction of movement. And so it ends up giving us a graph that shows the velocity and direction of the movement. And so we can see, because this is pointed downwards, that the tissue or blood is moving away from the transducer, and the distance that it goes down gives us the velocity. And so this is an example of looking at blood flow through the aorta, and continuous wave Doppler is very good for high velocity movement, and so it's very good for blood flow in the aorta. The drawback with continuous wave Doppler is that we can't look at just a specific point or just a specific object within our entire image, and instead it picks up everything that's along the entire line. And so we also see this artifact on the other side where we see something moving on the other direction, and that's because it's picking up the tissue movement of the heart in that direction. So pulsed wave Doppler is similar, except for that we're able to look at a specific point in our image. And you can see there's a marker right here that we only want to look at this point in the image. And so pulsed wave Doppler is much more accurate, and it has less interference from other parts of the image. And the reason it does this is because it just sends out ultrasound pulses and determines each of those pulses how long it takes to come back to the transducer. So it creates a similar image on our graph where we can see the direction of flow over time and also the intensity of flow. The drawback with pulsed wave Doppler is, because of the mechanism and because of something called aliasing, we can't use it for tissue or blood that has very high velocities, because sometimes the transducer will actually pick up the return signal and will think that it's moving in the opposite direction of what it's actually moving. And so pulsed wave Doppler is better for tissues with lower velocity. Next is color Doppler, and this is something that more of us are familiar with. Color Doppler allows us to look at direction of blood flow, is the most common way that we use it. And it's very important to note the key over on the left side of the image. You can see that anything that's moving towards the transducer or upwards is going to be red, and anything that's moving away from the transducer or down is going to be blue. And you can also see that there's a different gradient in each of these colors. And so something that has higher velocity flow is going to be a lighter red, and something that has higher velocity flow is going to be a lighter blue. And so in this image that we can see here, you can tell that the blood in this vessel is moving away from the transducer, whereas the blood in this vessel is moving towards the transducer just by the color of the vessel. And it's also important to remember that the blue and the red have nothing to do on whether it's venous blood or arterial blood. It's only direction. Another point is you may hear of duplex ultrasound, and duplex just means that it's two modes of ultrasound that are combined. And so, for example, some of the things we were looking at before, the combination of 2D ultrasound or B mode with color Doppler would be duplex ultrasound. Another important point is that color Doppler is also limited by velocity, and so if the velocity of blood flow is too high, then we can start to see the transducer not accurately pick up the direction of flow. And so we may think it's flowing one direction when it's actually flowing the other, just because the blood velocity is too high. So in the next section, we're going to talk about the different knobs that are on the ultrasound machine. This is a picture of a very old ultrasound machine that has a lot of knobs. It's very complex. The newer machines are much more succinct and easier to work with. And you can see that on this machine, we have the depth over here, we have the gain here, we have the type of exam, and then we can also select the ultrasound transducer. And so these are the things that we use most frequently. And it's important to note that every ultrasound machine is going to have these functions in different places, but they all have the same function. And so the most important thing is just familiarizing yourself with the machine that you're using so that you can use it well.
So depth is one thing we can use to optimize our image. And although it seems simple, it's often something that's overlooked. So you can see on this image on the left that the heart is obviously not fully in view. But if we increase our depth from 8 to 14 centimeters, then we center the heart, which is our object of interest, right in the middle of the screen. And so, of course, this is where we want it to be. It's also good to understand that sometimes people put our object of interest too close to the transducer in relation to the entire image, and so sometimes you'll see that the depth is actually too high and our object of interest is way up here on the top of the screen. And this is also suboptimal because the image won't be as large and the resolution won't be as good.
The next concept we'll talk about is gain, and the most important thing about gain is that it adjusts the image brightness by either amplifying or dampening the return ultrasound signal. So for example, if we look at our ultrasound beam that's going through different tissues, here the difference in impedance is much higher right here, so our signal is much stronger. And this strong signal will be interpreted as a much brighter image on the ultrasound screen, whereas the differing impedances later on is not as high, or it may be that just our ultrasound beam has attenuated to a point where the intensity coming back is not as high, and so that will be less bright on our ultrasound screen. But by using gain, we can make the parts of the image that are too bright, we can dampen them like this, and then we can take the parts of the image that are not bright enough and we can amplify them. And so our corrected signal is something that's much more uniform and much more easy to interpret. So again, gain adjusts the brightness by amplifying or dampening the return signals. So to give some examples of gain, you can see in image A that the near field, or the field towards the top close to the transducer, is too dark, whereas in image B the far field is too dark, and it's hard to pick out any objects in the far field. But we can use gain to optimize this and to make the brightness something that's more interpretable so that we can actually use it as needed. So over here on the left is another example where the image is too bright, and so we can't actually pick out the structures that are deeper in the image. There's poor resolution there, but if we dampen those return signals and make our image less bright, then the resolution is much better. So another important point is the exam type, and every machine allows you to select the different type of exam. So you can see here that we've selected an abdominal exam, and the machine is already programmed so that the resolution and the depth for each different type of exam is optimized. And so if we switch to a cardiovascular exam, then the resolution and the depth would be optimized for this. Same thing for a vascular exam. We'll briefly talk about the probe indicator. I know most of you guys are familiar with this already, but every transducer has a marker, and the side of this marker corresponds to the side of the orientation dot that we see on our screen. And so this marker helps us orient the probe on the patient, and it's very important when we start talking about cardiac ultrasound. So last I want to talk about different types of artifacts, and artifacts are extremely important. Obviously they're created by real anatomy, but they're not real anatomy. So oftentimes they're a source of misinterpretation. But at the same time, they can be very useful, and different types of artifacts can tell us different things about our patients. And the most common time that we use artifact is when we're looking at lung exam. The first type of artifact is called acoustic shadowing, and this occurs when the ultrasound wave encounters an object and when all of the wave is either reflected or absorbed. And so in this example, the object is a stone in the gallbladder, and you can see that none of the ultrasound wave passes through, and so we get an echo-free or an ultrasound-free area past this, and it looks like a shadow past our object. Another type of artifact is called edge artifact. And with edge artifact, it typically occurs with a fluid-filled circular structure. And the ultrasound beam comes to try to hit the side of the circular structure. And at the edge of the circle, it's actually reflected off. And so what ends up happening is that there's no ultrasound waves that come more distal to that. So again, we get this echo-free void at the edges. This is called edge artifact. Another type of artifact is called side lobe artifact, and this one's a little more difficult to conceptualize, but remember that our ultrasound transducer sends out waves in different directions, and it also has the central beam. But occasionally, a side lobe or a beam that's to the side of the transducer will encounter an object and reflect back to the transducer, but the transducer will think that it was reflected from an object within the central beam. And so when the real image is over here, it's picking up the image as being right here. This often happens in fluid-filled structures, and so you can see here that the duodenum is a reflector of ultrasound waves, and it reflects the side lobe waves of the transducer and sends them back to the transducer, but it thinks it's picking them up in the central lobe, and so it picks up artifact here in the middle of the screen. This obviously can be a point of confusion, but it's often the artifact often disappears with just small movements from our probe. So with posterior acoustic enhancement, the ultrasound beam travels through a fluid-filled structure most commonly. And the fluid-filled structure, the waves travel through very well. There's very little attenuation. And so because they travel through so well and then hit the tissue on the other side, the waves are reflected much more strongly after this fluid-filled structure. And so they appear much more bright. You can compare that to the tissue on either side of this fluid-filled structure, and you can see that it's more uniform because the waves are being reflected back the whole time, but because of the very little attenuation in the fluid-filled structure, the tissue at the distal part of that is much more bright. Another very important concept is that of mirror imaging, and in this scenario, the ultrasound wave travels and reflects off of a good reflector, and after reflecting, it encounters an object and then reflects back to the transducer. The entire distance that it took to come back to the transducer is occasionally interpreted by the transducer as having happened in a straight line. So the transducer actually thinks that it just went straight down and then went straight back up. And so it picks up this artifact on the other side of the reflector that's not actually there, but it mirrors the object that actually is present on the other side of the reflector. And so an example of this we can see here, here's our strong reflector. The part of the ultrasound waves are reflected off and then encounter this vessel and then reflect back to our transducer. But the transducer thinks that all of this happened in a straight line, and so it creates this artifact on this side. This is especially important when we're looking at the upper quadrants of the abdomen because we expect there to be a mirror image of the liver on the other side of the diaphragm. And when that mirror image is not present, then it's suggestive of a pleural effusion. Reverberation artifact is something we see frequently, especially with lung ultrasound. And this refers to the ultrasound waves being sent out from the transducer and then encountering some type of object that causes them to reflect. But then the ultrasound transducer doesn't actually pick up the return waves, and instead the waves are sent back out. where they reflect again off of the surface and then come back to the ultrasound transducer. So what ends up happening is that we see lines further down our image that are the same, just twice the distance as they actually are from the real object. And so here's our real object, two times away from that is this line, and then if it were to reflect more than twice and go back and forth 3 times, then we see this line, and then this line, and so on. And so with lung imaging, for example, this is the pleura in between 2 ribs, and we see that because of reverberation artifact, we see these lines coming down our field. And those lines, of course, are not real, and they're just because of a reverberation artifact off of the pleura. We also see another artifact in this image that we talked about previously. These are acoustic shadows because of the ribs that we're trying to ultrasound between. So here is ring down artifact, and this occurs because of a large mismatch in the acoustic impedance of 2 different tissues. And you can see that it creates these lines that travel all the way down our imaging field. And this is something we look at in lung ultrasound. The name for these lines in lung ultrasound are called B lines, and they come from the lung pleura right here. And they're suggestive of pulmonary edema. So they're another way that we can use artifact to look for different types of pathology. So that concludes this talk. Here are the references if you'd like a little bit more detail about some of these concepts.